I've structured this presentation where conventionally accepted facts are like in the white font, and the new updates are all in red. So it'll make it easier to figure out what's new and what's just old convention. And for those that need to leave early, I've put the summary at the top of the presentation. So this is what essentially my talk is all about. The cardinal symptoms are headaches and signs of papillaedema. They have impaired peripheral vision and color vision. People have an ICP. The new threshold is 25.
Abhay, there's some kind of weird audio feedback. I'm not sure that's on your end. Is other people getting that? It wasn't there before.
There was a plane flying overhead.
I don't know. Let's go ahead.
Can you guys hear me?
Yes.
Okay. Let me put the microphone closer to me. So the old threshold for elevated ICP was 20, but as new data has come in, the threshold is now 25, not 20 anymore. Now, obviously, CSF has to be normal, no infection or inflammation. You do have to exclude certain drugs and endocrine abnormalities to make the diagnosis. And therapies are wide-ranging, from conservative weight loss by diet or exercise, Diamox, or other calcium carbonic anhydrase inhibitors, to surgeries, and that run the gamut of optic nerve sheath fenestration, shunts, stents, and even bariatric surgery. So nothing to declare. I will be discussing off-label use of Diamox and Topamax that are not FDA approved for this indication, and shunts and stents. List of the acronyms that we use. I'm sure most of you are aware. The last one in particular, when we measure the pressure by a lumbar puncture, we are technically not measuring intracranial pressure, but cerebral spinal fluid pressure. It correlates really well with ICP, but it's not exactly the same. This condition has been called many different things throughout the years, and it was described shortly after LPs were invented by Quincke. And for a while, it was called benign. And clearly, if you lose vision permanently, that's not an appropriate acronym for it anymore. And the generally accepted description is IIH now. And we all know why it's called pseudotumor. When Dandy started operating on these patients, 9 times out of 10, this was before the era of imaging. If somebody had headaches and papillaedema, they found a real tumor. But when he did craniotomies on these patients, 1 out of 10 patients did not have a real tumor. So just some basic facts about physiology that we all know. We have about 150 ml in an adult. You make about 500 in a day. And these pressure ranges are important to keep in mind, as some of us see patients who are younger than 18. Their threshold is higher, around 28. And the normative pressures have been described in the left lateral decubitus position, and this becomes relevant when we do LPs under fluoroscopy or in different positions. These norms don't translate to those positions. We all know women are affected much more than men, that obesity is a very prominent risk factor. There are certain medications that have been described in multiple case series, including lithium, vitamin A derivatives, tetracyclines. Both high and low cortisol can lead to intracranial hypertension, and so does mixed edema. And we all know cortical venous sinus thrombosis is a prominent risk factor. So what's the update in regards to new risk factors? There are certain vitamin A therapies for cancer that can also elevate intracranial pressure. And some of the most widely used antibiotics, fluoroquinolones, that are used for UTIs and pneumonias in a certain segment of patients, can cause raised intracranial pressure. And we now know that independent of thrombosis, venous sinus stenosis itself can lead to high intracranial pressures by reducing absorption and increasing the outflow resistance of CSF. And we're increasingly realizing the role sleep apnea plays. Due to hypoventilation, you retain CO2, and carbon dioxide happens to be the most potent cerebral vasodilator, and that in turn leads to high pressures. And this is just some data from the continuous ICP monitoring that we do, just to orient everyone to the figure. Let me get the laser pointer on. So it's multimodal recording. So we record EKG, heart rate, respiration, intracranial pressure, and that's done with a Codman ICP Express through a burr hole, and we measure pulse ox. So this is, normal ICP, varies between 5 to 25. We are used to describing intracranial pressure as a single static measure, because when we do an LP, we don't get to see these fluctuations of ICP that are synchronous with your heart rate, essentially. That's because the LP needle acts as a low-pass filter. But if you do it with direct ICP monitoring, you see this beautiful ICP waves that are in perfect sync with your EKG. So this is somebody with normal ICP. What happens when you have sleep apnea? As you can see, you can see the desaturation that correlates with these apneic episodes. So this is normal breathing, then he has a short apneic episode, some more normal breathing, followed by a prolonged period of hypopnea, apnea. And you can see the oxygen saturation start to drop. It goes down into the 70s. And you can see beautifully correlated rise in ICP. And as you can see, the peak of the ICP goes to around 55 to 60 millimeters of mercury. That is like 80 to 90 millimeters of water. 80 to 90 centimeters of water. So really high ICP is in people with sleep apnea. And this is an extreme example of what happens when this happens throughout the night, right? So as you can see, every time there's a pause in the breathing, oxygen saturation drops, ICP goes up. Every time there's an apnea, hypopnea episode, ICP goes up again to 50 to 60 millimeters of mercury, which is very high. And obviously this leads to early morning headaches. So you all know the symptoms of headache, visual symptoms, pulse synchronous tinnitus. In some patients, we see horizontal diplopia due to involvement of the abducens, loss of color discrimination, metamorphia. Eventually, if you don't treat it, you get constricted fields. And generally, we are taught, constricted tunnel vision is non-organic, but in pseudotumor cerebri, it is organic. So what's the update in terms of the symptoms? Headaches, unfortunately, are not reliable in pseudotumor cerebri for symptom management, and we'll come to why that is. We are realizing the role that IH may play in cognitive impairment, and I'll touch upon cases of otorrhea and rhinorrhea. So these are patients with no history of trauma who have spontaneous CSF rhinorrhea or otorrhea, and we are finding that they have underlying intracranial hypertension. So headaches can obviously be due to high ICP, but often this is the same patient population that has migraine headaches, tension type headaches. They take NSAIDs and opiates for their headaches, and they develop medication overuse headaches. And we found, and others have described, that there are very few features that can distinguish them apart. So it becomes very difficult to manage these patients if you're trying to treat their headaches symptomatically with Diamox or shunts or stents. And just to give you some examples, this is what would be a typical patient. Somebody with IH has 10 out of 10 headaches, has optic disc swelling. And as you can see, this patient's ICP goes up to 40 to 50 millimeters of mercury, not associated with any oxygen desaturation or hypopnea. So this is independent of sleep apnea, and this makes sense. This is another patient who has no headaches, absolutely, 0 out of 10, has clear florid papillaedema, and has elevations of ICP synchronous with their sleep apnea episodes, but has no headaches. So you cannot rely on headaches. Conversely, this is a patient with 10 out of 10 headache with no optic nerve edema, and intracranial pressures were normal. They were between 0 to 20, no modulation by oxygen desaturation. So just to reinforce, while headaches happen to be the most common symptom, it's very difficult to use it as a metric to know if your therapies are having an effect, because headaches are multifactorial. Many patients will describe a brain fog, and we did a study of around 101 patients where we did detailed neuropsych testing on them. Around 30 of them had single domain impairment by more than 2 standard deviations from normal, and 25 had multi-domain impairment. And we thought that their cognitive impairment would correlate with how high their pressure was, how much papillaedema they had, how impaired their visual fields were. Did they use Diamox or Topamax or opiates? Did they have sleep apnea? And we found absolutely no correlation with cognitive impairment. The biggest correlation was with the HIT6 and the numerical rating scale. So essentially, cognitive impairment in folks with IH correlates with how bad their headaches are, and with measures of depression, but not with absolute measures of ICP or their vision. So generally, we are told that these patients should have a detailed, comprehensive neuro-ophthalmic assessment. You get fundus photos, grade their degree of papillaedema to visual fields by perimetry, to color vision by Ishihara plates or HRR plates, to your visual acuity, and do a retinal nerve fiber layer thickness with OCT. And we obviously need to do some kind of imaging to rule out a space-occupying lesion and an MRV, and obviously an LP to confirm the diagnosis. And typically you see these patients with severe papillaedema if they are untreated for a while. On imaging, you can see increased CSF around the optic nerve sheaths. As you can see on the right, it can be a bit asymmetric. In the coronals, you can see there's more CSF around the optic nerve sheath here, not much over here. So asymmetric papillaedema shouldn't dissuade you from making a diagnosis. The earliest changes would be an enlargement of the blind spot on perimetry. Eventually, obviously, if you don't treat, you're going to get constricted fields. So what are the updates? So you definitely need to get an MRV with contrast or a CTV with contrast. Just a time of flight MRV with contrast is not sufficient. And in patients who have venous stenosis, you should consider cerebral angiography and venous manometry to measure pressures across the stenosis to determine if they have a gradient that's amenable to stenting. This was an MRV with contrast of somebody with a significant sagittal sinus thrombus. You really don't want to miss that. And this is somebody with bilateral transverse sinus stenosis. You can see the lumen of the right transverse sinus and also of the left transverse sinus is reduced significantly due to stenosis. And obviously, we need to do the lumbar puncture. And the classic normal pressures have been described in the lateral decubitus position. Often in patients who are morbidly obese, we tend to get them under fluoroscopy. And as you may know, in fluoroscopy, they are put in the prone position, which is not exactly the same and can give you inaccurate ICP. And in some ERs, we often find patients are done in the sitting position, and we absolutely don't know what normal is in the sitting position. It doesn't translate to the lateral decubitus position. Clearly, the CSF analysis should be normal. Pressure should be more than 25, as I mentioned earlier, but in children, it should be about 28. There should be no anesthesia or sedation that will invalidate these measures because both anesthesia and sedation have been known to cause elevation of ICP. And to really get an accurate pressure, you have to make sure that the ICP waveform or the meniscus in your manometer moves with respiration, goes up with straining or coughing, and the legs and head need to be extended and in the neutral position. And this is important because the entire diagnosis depends on making an accurate measurement of ICP. And this is a study that I did with David Solomon, who was my colleague, who unfortunately passed away a few years ago, where we measured pressure in different positions, whether supine or prone, head left or head right. So just to the first figure, if you're in the neutral position, your pressures are going to be lowest. If you turn your head to the left or to the right, the pressure goes up by an average of 5 centimeters. And that can mean the difference between somebody with a pressure of 20 that's normal or 25 or 26 that's abnormal. So having the head in the neutral position is very significant. We did similar studies in supine versus prone, and in supine versus prone, head turning left to head right. And in general, the prone position elevates pressure by a mean of 4 centimeters. And that's why when you do it under fluoroscopy, you should request that they measure the pressure in the left lateral decubitus position and not in the prone position. And the criteria have evolved over the years from the 1920s when they were first described, and the latest update was in 2013. And Dandy made these beautiful line drawings before there were fundus photographs of patients with IIH that he treated. And he came up with the first criteria. But obviously the criteria have now evolved. And I'm just going to highlight a few important things that, we do need some evidence of papillaedema to make the diagnosis, and pressures should be about 25 in adults and 28 in children. When you convert to millimeters, it's 250 and 280 respectively. Very rarely should you make a diagnosis of pseudotumor cerebri without papillaedema, and only if you follow or satisfy all these conditions, meaning they don't have papillaedema, they have elevated pressures, but they need to have these criteria on MRI or an abducens nerve palsy. The problem with criteria for MRI is that they don't describe objective measures. So is a partially empty cella sufficient or a fully empty cella? How much flattening of the lobe? What is the amount of distension of the optic nerve sheath that's considered positive? And there's no clear quantitative measure of transverse sinus stenosis or a threshold for transverse sinus stenosis. There's a FAR grading, but it's not luminal diameter or area that's included in that. This is a conventionally accepted treatment, weight loss, medications, prednisone, surgery, either optic nerve sheath fenestration or shunts. And weight loss really works. Many studies have shown that, meta-analysis has shown that, and a recent randomized trial of bariatric surgery has shown that that weight loss definitely helps. The important thing is to keep the weight off. But not everyone with pseudotumor cerebri is obese, and how this wouldn't apply to people who have normal BMI. Diamox works. It reduces CSF absorption. The dose ranges from 500 to 4,000. Nearly everyone gets paresthesias, change in taste, and metallic taste. They can get shortness of breath, kidney stones. You need to monitor labs. Some practical tips. So you generally should start Diamox at a high dose at 1,000, and you should titrate dose to vision. Like, is their papillaedema improving? Are their visual fields improving? Not to headaches, because headaches are multifactorial. You can push the dose as high as 4,000. Extended release Diamox is generally better tolerated. And we generally give all the dose, 3,000, 4,000 milligram at bedtime of the extended release for two reasons. One, you have less side effects, they sleep away the side effects. And two, ICP is elevated during sleep as compared to the daytime. So our pressures, when we are sitting right now, if you were to put a ICP probe in my head, it would be 0 to -10. So our pressures in the sitting position are actually negative with respect to atmospheric pressure, or 0. So we really don't need the Diamox in the daytime, nor do people with pseudotumor. They really need it at night when they're lying down and when they have sleep apnea-related elevation. So we give all our Diamox at bedtime as a single dose, and it's well tolerated. You need to monitor BMP and their urine analysis to make sure they don't have hypokalemia or renal dysfunction or calcium oxalate crystalluria, which would be one of the earliest signs of kidney stones. And I'm not too concerned about metabolic acidosis because they all compensate with respiratory mechanisms, unless they are on a ventilator or they have chronic renal disease. So patients often nowadays can see their own results in my chart, and they'll ask, oh my God, do I have acidosis? You're acidifying my blood. And I always have to reassure them that if you actually check pH in these patients, they're all compensated. If somebody uses Diamox for a long period of time, more than 10 years, I do start getting worried about osteoporosis, and I start getting annual bone density scans. And for some reason, some patients tolerate metazolamide better than Diamox, so that's still an option. A lot of us are familiar with Topamax, and there's no direct ICP lowering effect of Topamax, but it does facilitate weight loss, and that's likely the mechanism by which it helps. The dose can be between 100 to 400, very similar side effects to acetazolamide, in addition to the cognitive impairment, which is more in Topamax and in Diamox. And obviously, you don't want to give it to somebody who is likely to get pregnant. Optic nerve sheath fenestration was one of the first surgeries described for treatment, and it's still applicable in those who are rapidly losing vision. The caveat is headaches rarely improve after optic nerve sheath fenestration. We don't know the long-term efficacy because eventually the fenestration seals up due to scar tissue and they need some other treatment or a repeat fenestration. And complication rates remain fairly high. And the complication rate from this, the dreaded complication is further visual loss due to direct injury to the optic nerve during surgery. So generally, neuro-ophthalmologists tend to avoid it unless there are no other good options. Shunts, again, have been around for over 50 years in different configurations. They are programmable now. They're very effective in lowering ICP. The problem is the morbidity and mortality associated with shunts, and the risk of infection, over drainage, under drainage is fairly high. This was a retrospective study at our institution where we compared how long are shunts effective, and they're terrible. Even ventricular and LP shunts, and at time 0, if all of them are working, by 36 months, nearly 80% of LP shunts are ineffective and around 70% of VP shunts are ineffective, meaning they need some kind of revision. So shunts are good for immediate lowering of ICP and for salvaging somebody's vision, but they are not a good long-term treatment. And this is one of the dreaded complications of shunts. You get meningitis and ventriculitis, and it can chew up the whole brain from inside. So what's the update? So there was a really good randomized study, the IH treatment trial, that looked at weight loss on Diamox compared to placebo and venous sinus stenting. So coming to the IH treatment trial, this was a multi-center trial of around 150 patients. They restricted it to people with mild IH, meaning they had to have mild visual field deficits with a mean deviation of -2 to -5. All of them got counseling by nutritionists with a low sodium diet to facilitate weight loss. And then half were randomized to Diamox up to 4,000 milligrams and half to placebo. And they were followed for around 6 months. And the results were that in terms of visual function, meaning perimetry, there was no clinically significant difference. There was a small statistical difference with Diamox being better. But in terms of actual visual function, they did not find any difference. Papillaedema did improve more in patients taking Diamox, but remember, papillaedema is a structural measure, whereas what you're really concerned is function, which is measured best by visual fields, by perimetry. So what are the implications of the IH treatment trial, which is if you have mild IH, weight loss is sufficient as long as you're monitored very closely by a neuro-ophthalmologist and are guided by motivated nutritionists. But the majority of our patients who have moderate and severe IH, there's clearly no evidence as to what path to go down to. Should we try drugs first? What's the role of surgery? And that remains an open question. So we were one of the first to describe a case series in the US for venous sinus stenting, and there have been many more studies and largest case series since then. And we looked at 12 patients who had failed maximal medical management. We followed them for 2 years, and papillaedema and visual function improved in nearly all of them. But headaches, again, improved in only 6 of the 12. And again, your therapy monitoring should be based on visual function, not headaches. This was a cerebral angiogram, and venous manometry was done. There was this intermediate segment stenosis in the right transverse sinus, and the right figure is after stenting. A little better view with CT venograms, where you can see the short segment stenosis in the right transverse sinus, and after stenting, it opens up really well. This was the pressure pre-stent, and it went up to 30 millimeters of mercury. And after stenting, pressures were normal, around 0 to 5 millimeters of mercury. But there are caveats about venous sinus stenting. For reasons we don't understand, it doesn't work well in African Americans, at least in this small case series that we published recently. And it doesn't work if you're obese. So generally, the people who are affected by pseudotumor cerebri, if you have class 2 or class 3 obesity, which means if you have moderate or severe obesity, essentially, if your BMI is more than 35, venous sinus stenting doesn't work for you. So we are still trying to tease out the right patient population for selecting patients for venous sinus stenting. So to summarize, IH is due to some combination of obesity, stenosis, sleep apnea, and medications. It's not a single disease, and the risk factors may differ in different people, even though signs and symptoms may be common. And there are several unknowns that remain. Why are women disproportionately affected? There's probably some role of hormones, brain lipids, the venous wall size or structure in women as compared to men. That's something we are exploring. And we still don't know what causes intrinsic versus extrinsic venous sinus stenosis, and why some people with venous sinus stenosis develop it and why some don't. So I would like to thank, and this is a old photograph, as Rich likes to show, and he was part of our center, and he was critical in establishing the Center for CSF Disorders at Hopkins. So can we take questions, Rich, or should we go into some quiz? It's up to you.
No, Abhay, we can take questions. And thank you, first of all. Yeah, that was a long time ago. And please, anyone who has a question, either put your name or the question in the chat, and we'll call on you.
Okay, I need to look at the chat.
No, I'll take care of that, Abhay. So in the study you referenced, people with mild intracranial hemorrhage, intracranial hypertension, did headaches get better on treatment? You didn't mention that.
Which study, Rich?
The ones with mild intracranial hypertension, you said their vision didn't change, but did the headaches improve on the treatment arm?
This study?
Yeah.
The IH treatment trial? Headaches were no different.
Huh.
Yeah.
Okay. All right. Tim Collins?
Yeah, I'm here.
You had a question?
Yeah, so we see a lot of these patients in the headache clinic, and I was wondering how often do you do intracranial pressure monitoring with a bolt in the group of patients that have this fanatical belief that their pressure is still elevated while they're on treatment because their headaches are still present. We've done this in the past a couple of times, and it's gone okay with our patients, but they always end up angry because the results don't confirm their bias. Do you guys do that up there in your service?
We often do them, and often it's primarily because they don't have a good explanation, and it's to satisfy them essentially. There are some times, rarely, we do find underlying IIH that's just evident only with ICP monitoring, that daytime LPs have been normal, but I would say that's less than 5% of our patients. And I agree, it's very difficult to convince them without doing this ICP monitoring that the headaches are in fact not related to any measure of ICP.
Okay, Abhay, a question from SC. I don't know the name for SC. Do you want to ask Abhay your question? SC? Okay, I'll ask it then. So Abhay, is there any recommended long-term treatments for managing headache in this population of patients?
I think generally trying to figure out the underlying headache type is the first step. Is this medication overuse headache? Is this just a transformed migraine? Is it tension type headache? And then conventional methods of treating them. Some of our patients need CGRP antagonists, Botox, Cephally, so all the usual armamentarium that you use for headache disorders, depending on the underlying headache type, needs to be applied to this group of patients. And this is the same group of patients who are in the demographic where they have comorbid headache disorders, and it is a challenge to treat them.
Carolyn Pizzoli has a question.
Thank you so much for a great talk. I really have learned a lot that I think will change how I practice, particularly in the Diamox dosing. And but to this question specifically about how my takeaway is that the headache is often refractory, and I think that's one of your points, is that it's multifactorial. Is there any experience you have specifically in people with a secondary cause of their increased CSF pressure? I've had children, I'm a pediatric neurologist, post-ADEM, well recovered from ADEM, and also post-HIE, very, very far out, who present with some persistent morning headache patterns, and I test their pressure and it's elevated. No papillaedema. I get partial response to Diamox. And so based on this, I'm thinking I should move on to other treatments maybe more quickly than I have been otherwise. And I guess I wanted to confirm that would be your recommendation. And also, do you have any secondary experience with these secondary causes of persistent increased pressure in these groups who had, inflammation or injury?
Good question. So, we definitely need to rule out venous sinus thrombosis or stenosis in these patients who've had some kind of neuroinflammatory syndrome. Because if they do have underlying venous sinus stenosis, then you can directly address that with manometry and stenting. But Diamox is not a great drug for managing pure headaches if they don't have any optic nerve swelling and you're not able to follow them over time by vision. And yes, I would transition to headache-specific measures quickly. And for these group of patients, I think Topamax works better because it's a much better drug for headaches in general than Diamox.
So Catherine Colton, are you out there?
Hi, good morning. So I'm one of the ED providers, and we don't always see patients in a center like this where we can get them to a neurologist in timely fashion. So are you taking, like, if we're doing an LP, as you mentioned, sometimes we do them sitting up just for ease, like, do you actually want our opening pressure? Or are you going to actually take that in their diagnosis, or are you going to do everything again?
Yeah, just because we don't know how these sitting pressures translate in terms of normative data, that's all done in the left lateral, right lateral decubitus position. It's tough to know how to interpret these pressures when done sitting. So we would generally tend to repeat it in the lateral decubitus position.
Okay. And if we, if someone has a great story for this, they're totally miserable and they feel better after we take some fluid off, is that going to delay their evaluation? Like, I know it can change your imaging. Is that something you actually want ED providers to be doing?
And Catherine, if I could add, the next question from Tim Collins is exactly on point to what you just said, because he said, Abhay, could you comment on the fact that people get relief of their headaches with a lumbar puncture, even when their pressure is normal?
Yeah, people appreciate it.
Yeah, there are certainly caveats to that. To address your first question, if somebody has papillaedema and their CSF contents are normal, generally, it's assumed they will have underlying IIH, and your pressures may be inaccurately measured sitting or lying down. But if they have clear papillaedema and the CSF is normal and there's no structural abnormality, the pressure measurement becomes a bit secondary to your treatment, your immediate treatment. Yes, in an elective manner, you would repeat the LP in the correct position, but that shouldn't delay their treatment, and you would definitely start them on Diamox right away. What we generally do, and we get often patients referred from the ED for this, what we generally do is when they finally do end up in a clinic, we ask them to stop the Diamox a week before repeating the LP so that we do get that correct measurement, so that we can titrate their treatment going forward correctly. So we have them stop the Diamox a week before the LP. It's all washed out. We get the correct opening pressure in the right position. But I agree, it shouldn't delay their treatment when you're seeing them in the ED. And the second problem, and the second question is very relevant. What do you do when patients report, even patients with normal pressure report relief of their headaches? And we found that to be a very poor predictor for future management. And the reason is multifactorial again. Ultimately what causes headaches in migraine is meningeal irritation. The trigeminal afferents in your meninges are firing abnormally. And your meninges are under a certain amount of stretch because of normal ICP. So if you reduce that stretch by lowering ICP, those afferents are not going to fire as much. Even in people who are completely normal and have normal pressures, those trigeminal afferents transiently are going to fire less when they're under less stretch. So even patients with just conventional migraine, if you do an LP, they will say that their headaches were better for hours or a day or two. So that's actually not helpful in management. Almost 90% of the patients that we do LPs on, even if they don't have underlying IIH or pseudotumor, will in fact report that their headaches get better.
Yeah, but a question from Dr. Marvin Rozier, and I'll add to it. He said, Marvin asked about pseudo-papillaedema, but I'll make it even broader, which is when I'm in resident clinic, we see a lot of people with chronic headaches who are overweight and hardly ever get a good look at their optic disc or even know what we're looking for in mild cases. Would you say in that situation, a better screening test would be things like Ishihara plates or something like that, rather than all this wasted effort to look at someone's optic disc if you're not as experienced as you?
Yeah, one thing we do is have eye drops in our clinic. So generally we dilate their eyes, and that definitely gives you a better image. So you can use tropicamide or phenylephrine or a combination of that. and we generally do that right after their vitals are done. So by the time we are at the end of our exam, the pupils are dilated and we can see much better. But I agree, in some of these patients, it can be very difficult to see the disc, or people with prior papillaedema, they'll develop gliosis from the prior papillaedema, and then it becomes difficult to figure out, is there active papillaedema or not? And again, I agree with you, Rich. I put more emphasis on function, visual function measures rather than structure. And color vision is very sensitive for any kind of optic neuropathy. So I do measure color vision with HRR plates, which are more sensitive than the Ishihara plates.
What's the name of those plates, Abhay?
HRR, Hardy, Rittler, Randy plates. I can send that to you by email. And you just look at 10 plates. It takes less than 2 minutes to do that assessment. So that's a very good functional test. And we do visual acuity in a bit more objective fashion with an ETDRS chart instead of a Snellen, because of the logarithmic scale involved, so that we can track these patients forward. But the important thing to remember about visual acuity is that it is the last thing to be affected in pseudotumor cerebri. So you cannot use it as a measure of treatment efficacy. In fact, if you have a patient with pseudotumor cerebri who has impaired visual acuity, it's too late. They have already lost a significant amount of optic nerve.
And what about pseudopapillaedema?
Yeah, that can be very tough to determine just on a bedside exam unless you have OCT. So OCT is like the gold standard now to determine if there's underlying drusen that's given the appearance of pseudopapillaedema. So in those patients, I would strongly recommend referring them to your neuro-ophthalmologist.
Okay. So Abhay, keep the questions coming. So about a month ago, I was in a conference and I told some folks that you used to say that the CTV was the gold standard for stenosis, but you think MRV is as good now? Yeah,
I think MRV with contrast is 3D reconstructions as long as they're good. The kind of CTV we have is a high resolution 320 slice CTV that many centers don't. So at our center, the 320 slice CTV is still better than any MRV out there.
Okay, so you still feel that?
Yeah.
Okay, I'll have to see how many slices we have here. Okay, no other questions?
Hey, Rich, can you hear me?
Yeah, loud and clear.
I've been amazed by pseudopapillaedema, and you really can see drusen in the optic disc. They're kind of shiny and lumpy, and sometimes they can just cover the whole disc and really look like papillaedema. They can even be associated with hemorrhages. But when somebody has hemorrhages anyway, they're going to go see somebody else about it. I've recently found out that there's another type of pseudopapillaedema, and that's diabetic papillopathy. And so we had a guy with what looked like papillaedema, and it turned out the only thing we could blame it on was diabetic papillopathy. He just needed better treatment for his diabetes. I've also been taught that if you can see spontaneous venous pulsations in the disc, then you don't have to worry about increased intracranial pressure. Is that true?
That's absolutely right. So if you see SVPs during your fundoscopic examination, you can be reassured that ICP is normal. With the caveat that 20% of patients with normal ICP will not have SVPs. So you just have to remember that.
I know you don't, absence of them doesn't mean you're abnormal, but presence means you don't have ICP.
Absolutely right.
Thank you.
All right, great questions. Abhay, again, we're indebted for your expertise, and thank you for taking time out to talk to us.
Happy to do it. Thanks for inviting, Rich.
All right, everyone, have a safe day.
Bye.